presentation. Our final speaker is Dr. Paul Tambyah. Paul is the Associate Professor of Medicine in the Department of Medicine of our own medical school. Paul, please.
I'd like to thank the organizers for inviting me for this. I'd like to state right from the beginning that I'm really excited to be allowed to present this. In fact, it was Lena who invited me, and she specifically said that I played a central role in drafting the STP's National Healthcare Plan. But I'd like to issue my own personal disclaimer, which is that I'm merely presenting the work of a committee. I'm not representing NUS or NUH, I have to say this. And these are what I do in my spare time or my extracurricular activities. People ask me, why do you get involved in politics? I'll tell them I'm not the only one. There's a whole bunch of public sector politicians. They all come from SGH, though, for some reason, or Sing Health. And in terms of the universities, I think NUS outnumbers NTU in terms of that. So I don't think that's too much of an issue. So what I'm going to be presenting today is what we presented a year ago. The Straits Times gave us half a page, and since then we haven't had any hearings at all. So I hope you'll forgive me if I go into a little bit of detail with some enthusiasm. These are the people who are responsible for putting it together. The first draft was actually written by my classmate, Dr. Tan Lip Hong, who is a very passionate, who feels very strongly about healthcare financing. The majority of those in this panel are general practitioners. I was selected to present it because I was an NUS debater, but that's besides the point. The fundamental issue in terms of the SDP healthcare plan is this belief that healthcare is a basic human right. And we challenge the idea of moral hazard because, this is from our good friend Leslie Chew, who does Democratic, which describes a fictional country, where he talks about people who try and abuse free healthcare. And this guy says, you mean you would go for an open heart surgery just because it's free even if you don't need one? No, but that's only because I don't have a heart, which is a little bit of a caricature. Human rights are not alien to Singapore. As you all know, human rights were integral to Singapore's history from way back in the 1950s as part of the struggle against colonialism. The principles of our healthcare proposal are three. Firstly, universal, affordable healthcare coverage to all Singaporeans. Secondly, to increase government spending on infrastructure and human resources. And thirdly, is a sustainable system with a single controlling body to tighten medical audit. So right at the beginning, I want to agree with Dr. Lam in the first point, which is that Singapore has a very good healthcare system. Okay, healthcare in Singapore has been very good for many, many years. Way back in 1950, you can see that the infant mortality rate was brought down dramatically from the rate that it was in the 1940s. And this was achieved through maternal and child health clinics, which are scattered throughout all the kampongs all over Singapore. And this is a paper published in the British Medical Journal in 1964 by the then Department of Social Medicine and Public Health. And this has been actually sustained over the years as we've seen reductions in infant mortality rates, which are comparable to some of the wealthiest countries in the world. However, the problem has been in the funding of healthcare. Now again, these updated slides from last year's presentation, but basically the total healthcare expenditure in Singapore, as you've heard, is 4% of our GDP, which works out to about $12 billion. Of this, government spends $3.5 billion. And if you go to the MOH website, you'll see that the government expenditure on healthcare represents only 1.2% of overall GDP, which is actually one of the lowest in the world. And again, Dr. Phua has mentioned, is that we have this idea of the 3 M's, and people think that the 3 M's are what actually makes up Singapore's healthcare system. And again, he's talked about that very eloquently, so I won't go into that in detail. But the reality is the 3 M's are only a very small part of total healthcare expenditure. Again, as you've heard from Dr. Phua, employee benefits, government health spending, and out-of-pocket expenses account for the vast majority. MediSave, MediShield, MediFund account for no more than 15% of total health expenditure in Singapore. I'll give you the details. MediSave, $761 million in the last year that data were available. This is, I think, 2010. MediFund, $84 million. And MediFund itself has its limitations. This is from one of our patients, where you're told first exhaust self and immediate family members' MediSave accounts. So in other words, that's what family responsibility means, is that you actually essentially are transferring the cost of healthcare to the next generation, which was the idea. You try not to tax people, but in the end, through making children use their MediSave to pay for their parents' illnesses, you are de facto transferring the cost to the next generation. MediShield accounts for 386 million. So if you add up these numbers together, 761 million, 84 million, 386 million, that actually comes up to barely over 10% of the total health expenditure in Singapore. And MediShield, this is a response to a parliamentary question by Mr. Gerald Giam, is actually one of the world's most profitable insurance schemes. Because if you look at that, in terms of the premiums collected, from 2005 to 2010, they collected $1.7 billion in premiums, but they only paid out $962 million in premiums. So the loss ratio of MediShield is actually way superior to most insurance schemes globally. The reason for this is because MediShield has many exclusions. Okay, this is, for example, from the CPF website. You can see that any illness, pre-existing illness, during the 12 months before the start of MediShield cover is excluded. Congenital abnormalities, fortunately, if you're born after March the 1st, 2013, your congenital abnormalities are covered. If you're born on February 28th, too bad. Okay, it's not covered anymore. Mental illnesses and personality disorders, and in my field, any treatments related to HIV and AIDS. MediShield premiums are also very high, and in a very perverse manner, MediShield premiums actually rise with age. So if you are 84 to 85 years of age, your yearly premium is $1,100, which is actually a considerable amount of money to people who are not really earning a lot of money. The other reason why MediShield is so profitable is because the deductibles and co-payments are significant. And there are limits. The deductible for MediShield has just been raised for B2 class to $1,500 if you're under the age of 80, and if you're over the age of 80 to $3,000. Now, this is actually a considerable amount compared with the average cost of hospitalization at the 90th percentile, which comes up to about $2,000 to $3,000, depending on which hospital you're at. So in other words, when the cost is so high, you can't use MediShield because the deductible has to be paid in cash or MediSave. So that actually makes MediShield what it really, really is, which is a catastrophic health insurance policy. It's not a health insurance policy for your normal hospitalizations, but it's a catastrophic policy. And in fact, the previous health minister had actually acknowledged this. This was in February of 2011, where again, in response to a parliamentary question, he was asked the amount of Singapore's healthcare expenditure that was financed by the 3Ms. And he said the 3Ms are intended primarily to help Singapore residents with their inpatient care and to a lesser extent some outpatient care. It is more meaningful to measure the contributions of 3Ms to inpatient care, where he said it was about 29%. Compared to about 30% from government subsidies and the rest being out-of-pocket or employer-funded healthcare. Jeremy has written this issue about health insurance, and the fact is that the majority of individuals in Singapore do not take up health insurance, especially those who might need it the most, and partly because of the severe limitations. So although public expenditure on healthcare is low, out-of-pocket expenditure is very high, and this is compared to other developed countries. In fact, in this article in Health Economics, you can see that the out-of-pocket expenditure in Singapore is way higher than other Asian countries. In Japan, for example, the bulk of healthcare expenditure actually comes from social insurance, as opposed to taxes. In Hong Kong, of course, the bulk of it comes from taxes, whereas in Singapore, the bulk of it is actually considered out-of-pocket expenditure. The result of which is that people actually, even though they are not denied healthcare for catastrophic illnesses, when it comes to early illnesses, they tend not to seek medical attention because of the fear of this out-of-pocket expenses. This has actually got a lot of implications in terms of people who avoid screening and treatment. And this is a study done by by a group from the university, where they looked at individuals looking in Taman Jurong neighborhood. This was in rental flats. And why people who, they did simple measures, blood pressure screening. So a lot of people didn't know they had high blood pressure. If they knew they had high blood pressure, they didn't take medication for their high blood pressure. And the reason was simply because it was too expensive. They didn't feel anything. When you have high blood pressure, you don't really notice it unless it gets really, really high. So they don't seek medical attention until it's too late. And what happens when it's too late? They have a stroke, and it's very disabling. The cost to the family, and in fact, the cost to the healthcare system is tremendous. It's not just in high blood pressure. Again, the same group, Gerald Koh and colleagues from the School of Public Health, looked at the socioeconomic factors affecting colorectal, breast, and cervical cancer. And they went out of their way in this rental block to try and get people to offer them free screening. And you see that there's still that reluctance to go. The people felt they couldn't take time off work to go, or they just didn't feel the understanding of the need to go for screening. Diabetic foot problems are a problem I see on a regular basis. And this is, again, in a large study done at the university, where they've shown that income and ethnicity were independent risk factors for diabetic foot problems. In fact, one of our orthopedic colleagues pointed out, this is a problem. 700 people in Singapore get an amputation for diabetic foot every year, and none of them are in the A-class wards in the hospitals. They're all in the B2 and C-class wards. And it's not related necessarily to compliance, but it's to socioeconomic factors associated with that. So there is this problem of payment, and it's true that nobody is denied care. But what happens is that you've got these outstanding patient debts. And again, this is data published in Singapore's most widely read medical journal, the Straits Times, where they pointed out that Singapore public hospitals have $110 million in outstanding patient debts. And in fact, when it comes to bankruptcy, this is from Credit Counseling Singapore, the top reasons for indebtedness in Singapore, number 1, overspending, number 2, job-related, and number 3, actually medical. So it's true, you will not be denied, but you're going to have that cloud of debt and bankruptcy hanging over you. And we believe that nobody should have to go bankrupt because of healthcare. Okay, again, a caricature from my friend Chu. How would you settle the rest of the bills? By cash, by check, by credit card, by selling your house, by selling your kidney? Hope not. So the other consequence of this system, okay, like I said, it protects you. It's from a catastrophic situation, but it results in hospital centricity, which results in overcrowding, unequal access to care, and inequities in public health care. Again, this is an article written in the Straits Times by Professor Lee Wei Ling, where she describes a friend who was admitted to one of the public hospitals, not the one that she's in charge of. And she said that this person never saw the consultant in charge until she wrote a note putting her name and handphone number. The minute the doctor saw the note, he telephoned the head of department. My friend had never seen or heard that person before. Other doctors asked, who are you and how are you related to Professor Lee Wei Ling? An hour later, the head of department called up, gave her the details, sent a bouquet of flowers from the hospital, and a senior doctor took care of the friend's husband and performed every operation on him personally. So it's really sad that in public hospitals, apart from the NNI, the people who are in the C-class wards do not get the same kind of care. And this has resulted in unsustainable healthcare cost inflation. Again, this is data from Dr. Lim Meng Kin, who recently passed away, where he showed that what has happened is that healthcare expenditure has gone up tremendously, but the genius of the Singapore system is government expenditure has not gone up at the same rate that private expenditure has gone up. And this continues. Even just recently, we see that it's going up by about 11% a year. So we need a new healthcare plan, one that's affordable, sustainable, and universal. So the key features of this plan, larger government contribution, increasing in government spending, and we think that this can be done through many ways, through small taxes, through shifting the burden of expenditure. And again, I've got nothing against MINDEF. I'm, as you know, a volunteer with MINDEF. I get awards from people there. But it's actually going back to where we were. In 1965, as you heard, Singapore spent 50% of its, 50% of healthcare financing came from the government. All we need to do is just go back. That didn't have any adverse effect. The fastest growth in Singapore was in the late 1960s. And that was when the government was spending 40–50% on healthcare. So it is possible to do this. We want to avoid the American model, as everyone here seems to be saying, where America actually has got very low government contribution to public healthcare. So we propose a single-payer universal healthcare system, which will be run along the lines of a government-subsidized public insurance system to finance compulsory basic health insurance. We want to get rid of the 3Ms and have a simple system, which is a single, the current 3M system is very difficult to navigate. So it'll have a fixed premium for Singaporeans, for PRs a slight bit more. It'll be income adjusted so that those who are poor will be subsidized. Older people who are not working do not pay, and we share the cost. It's a compulsory system. As Kai Hong has pointed out, once you allow people to opt out, then you're going to run into trouble because you're going to have all this adverse selection. People are not going to buy insurance until they really need it. So there will have to be an additional safety net for the poor. There'll be a healthcare benefits card. And again, I'm running out of time, so I'm going to have to cut through some of these. So what we're going to do is, in addition to that, because it's a single insurance system, and rather than a complex mix of systems, there will be a strong regulatory framework. And believe me, Singapore is really good at regulatory frameworks. Okay, if any of you have tried to buy anything or to sell anything, you know how complicated it is. So we want to return the Singapore Medical Association guideline of fees, single class wards, eliminate hotel services. Skip through that. And the other thing is stepping up the use of IT, a health benefit staff smart card that can be used both in the public and the private sector. So breaking down the walls between the public and private sector, which is actually one of the major concerns in Singapore. There's always been this distrust between what the, people feel that the GPs cannot be trusted. But if the GPs cannot be trusted, then, there's really no way that we can do anything about it. So reinforcing intermediate and long-term care facilities. The other issue is this problem of a hospital-centric approach. Last minute, I promise you. Okay. So, you've heard about how, as Kai Hong has explained, there's this big gap in this chart as to how healthcare works. And the issue is that we have good hospitals, we have good public hospitals, but the trouble is that the government does not provide any nursing home facilities at all. They depend on the VWO sector. And it's very, very difficult to do that. The result of which, again, this is from Straits Times, where they pointed out that 7 to 10% of patients in hospitals could be discharged, but there's simply no nursing home beds for them. So in summary, what this plan involves: larger government contribution, public health insurance system, evidence-based regulation of insurance payments, co-payment with caps for outpatient and inpatient care, and responsive long-term care at the point of need. Thank you.
Oh.